Hello and welcome to another episode of Keeping London Healthy. I'm Dr. Mario Elia. We've been having a lot of questions lately in the office about measles, people hearing it about in the news, so I thought I'd bring on Dr. Zain Chagla. He's an infectious disease doc out of McMaster to answer some of our questions, and we'll be joined by Dr. Chagla right after this message. All right, welcome back. I'm thrilled to be joined today by Dr. Zain Chagla. You may remember Dr. Chagla from our earlier episodes where we dealt with COVID on a monthly basis. Thankfully, not having to deal with COVID nearly as much now. But sadly, we're dealing with a new virus that has reemerged. So Dr. Chagla is an associate professor of infectious diseases at McMaster University, and he's agreed to join us today. Thanks, Dr. Chagla.
Oh, thanks for having me, Dr. Elia.
So this is one of those depressing episodes where we have to unfortunately talk about a condition that we thought was pretty well gone and didn't have to deal with. And that's, of course, measles. I know people have been hearing a lot about that in the news, and we've gotten a lot of questions, obviously, in our family practice. And I'm sure as a specialist, you're getting a lot of questions about that today. So I'm going to delve into that a little bit today. So let's start off kind of basic question. What is measles?
So measles is an infection that's caused by the measles virus. This is an infection that's been around for a long time. It's really, been well described for us for many decades, and is incredibly infectious to others, and why we get very worried about seeing transmission happening locally, particularly in the last few months.
And when you say the contagious of it, like again, we've been kind of in COVID land for kind of 4 years now. How does it? So someone in a room with measles with others who haven't been vaccinated against measles, how infectious are we talking about here?
I think COVID's a great example, right? So both viruses, both are spread through respiratory contact, although measles is very airborne in the sense that it stays lingering in the air for a long time. So, if you think about COVID, the average person with COVID may infect 2, 3, 4 other individuals by the time their infection is done. Those same estimates for measles are about 12 to 18. So, by the time a person is done being infectious to measles, they may infect 18 more people with measles if there's no immunity in that population. And even in our way we track measles and do infection control for exposures to measles, we talk about someone being infectious who's been in the same room with another person for 2 hours. So if I'm in that room with you, if I'm in that room and you come in that room, even if I've left for 2 hours, you're still at risk of being exposed in that sense. So this is really, one of the most infectious viruses we know, one of the most infectious diseases we know in terms of the ability for it to spread person to person. And this is why really prior to a certain age and era where we had vaccinations, it was almost guaranteed that everyone would get measles at some point in their lifetime because of how quickly it spread across the population.
And what symptoms do we see with measles? Like how does someone normally present?
So typically about a week after people are exposed, so it's a bit variable, they start getting the what we call prodromal symptoms or early symptoms. Those are cough, conjunctivitis, so red eyes, congestion and runny nose, and in individuals they can get a bit fatigued, malaise. Doctors after a couple of days can often see some white spots in their mouth called Koplik spots. And then about 4 days after the development of those symptoms, we see the onset of the characteristic rash. And that's really what we remember from measles in the textbooks and the pictures. This tends to start as a rash kind of on the face and cheeks that gets really, really red and really comes together going down into the neck and then spreads down the rest of the body. And often, again, really is what tips off people to think that measles is the cause of these symptoms, and classically what we see in the textbooks in that sense.
And you mentioned some of the symptoms there, and just to give people a sense, with again, bring this back to COVID again. When here's like the 10 symptoms you can get, but everyone gets kind of a different combination of them, similar with measles, that they don't have to have all the symptoms necessarily, but it's kind of a menu of them.
Absolutely. Like, the rash can sometimes be atypical, may not look exactly the way it is in the textbooks. People may have very minimal kind of cough and congestion. They may not have the red eyes. Doctors may not see those spots in patients' mouths, so there is some variability. That being said, most people, especially people who are not immunized to measles, who are exposed to it, about 90% will develop the disease when exposed, and most people will have at least some of the symptoms in that sense. There's very little people that are, quote, asymptomatic from being infected.
So one of the things, so as a family doc, again, I'm in my second decade of practice now, and of course, I've never seen measles my entire career, nor have most of my colleagues. I'm not sure if you have kind of as an infectious disease doc, but the not the frustrating, alarming thing from my standpoint is a lot of these symptoms obviously overlap with things that we see quite frequently, right? So we see Coxsackie virus causing rash in kids. We have just general viral rashes that kids get in general. Any reliable way from your end to distinguish this from other viruses apart from the complex spots, which you may or may not see, or is it kind
It's
of the clinical exposures that you're looking for that would make you more?
Yeah, I agree with you. The symptoms are important here, and where kind of clinical exposures are. So if people have been traveling recently, have they been around contacts that have had measles or other rashes that have been not described? Again, the classic measles rash tends to be very, very involving of the face. So, seeing a rash that doesn't involve the face at all is a little bit atypical. That being said, we do know people who, for example, develop measles after adequate or inadequate vaccination can often have very atypical rashes, sometimes look less of that maculopapular, the red spots can actually be a bit bumpy and look like blisters. And so again, those are suspicions and certainly can help with raising or lowering the differential diagnosis. But again, it's absolutely frustrating that this can mimic other viral infections, post-strep rashes, hand, foot, and mouth disease. That it's very, very hard sometimes to peel these apart, and often we're left with, as clinicians, especially in the context of transmission occurring on our soil, now having to consider it as part of the differential diagnosis.
People may be hearing kind of us talk about these symptoms and thinking, well, it sounds like a virus that sounds like it'll clear on its own. Why are we so concerned about measles? Like, what are the true risks of this?
Yeah, so absolutely, a good number of people do well from this, and I don't want to deny that prior to when people were infected with measles, that the large majority of people did well. When we look at more modern case series, and again, there is some issues about finding every case and that piece, but we see up to, depending on where you look, about 15% of people who develop measles end up being hospitalized for it. Now that's probably, again, the number is probably closer to 1 in 100 to 1 in 1,000, but because those are the cases we find, they're the ones that tend to be the ones that we follow a bit more aggressively. But there is that piece. So there is a hospitalization risk. Now measles can, as it gets through the body, can do a number of things. They can get to the brain, for example, and cause brain injuries. People can be quite debilitated in the short term and the long term from it. And that is a challenge. And the other unique part of measles that really causes much of the concern around this is that while people develop their immunity to measles after they're infected, the virus actually starts limiting the immunity, actually reversing some of the immunity to other common things that people have been exposed to. So in the measles recovery phase, we see individuals develop secondary infections. So they can get bacterial pneumonia, they can get ear infections. We see herpes viruses reactivate and people get another rash, sometimes getting into their eye, leading to blindness. And so people are left with not only having to deal with measles, but now having to deal with a myriad of other things that they thought they were immune to that are now causing issues and again, affecting the recovery and unfortunately sometimes leading to significant damage, including, respiratory issues and blindness.
Glad we talked about that because that's the biggie that we're concerned about. Because yes, there is that hospitalization risk, which obviously we take seriously, but it's the kind of resetting in a way of someone's not complete reset, but kind of a regression in their immunity to other common conditions that their body has worked hard over years
Yeah.
in acquiring and to have those diseases risk coming back for an individual is quite unfortunate. Can you talk us a little bit about the history of it? Because I know when patients are calling us worried about, well, have I been vaccinated in the past? I don't know if I got it or not. Kind of what was measles like up until the era of vaccination? We heard the term endemic. So like, what does
Yeah.
that mean?
Absolutely. So, historically, obviously, prior to vaccinations coming to the market, measles was endemic around the world, and really, in the 1960s, 1970s, just prior to the vaccine come out, there was some improvement in transmission, recognizing that people were in better houses, there was better infrastructure, and so that helped a little bit with limiting transmission. And then the advent of the vaccine, which really then came into the 1970s and early 80s, really then progressively markedly reduced the risk of disease in the community. And for example, 1980s and 1983, particularly in Canada, measles was introduced as a one vaccine campaign in children. And that actually had marked effects. Essentially, it was decreasing, but essentially, sent the number of cases down to, several dozen a year from several hundreds to several thousands a year. And then we did note a few individuals who were fully vaccinated or at that point one dose vaccinated had measles despite having a vaccine, and showed that really having a second dose of vaccine, at least a month after the first dose of vaccine, really did do a number on the population to actually reduce that risk even further. And that's where, the two-dose vaccine series really comes from. That was introduced in about 1996. So there's about a 13-year lag there when we went from 1 to 2 doses. And so, again, in the history of things, we consider people who were born before 1970 likely exposed during their lifetime because of the fact that measles was really endemic. It was here. There was not really much control. And then after 1970, because some of those controls that were in place, that they were less likely to have measles through natural immunity or natural infection. And certainly, again, as we started getting into a mass vaccine campaign, that there are now populations that have received 1 or 2 doses of a vaccine, which again, as we go for 2 doses of vaccine, and anyone born after 1970 who are kind of never exposed to it is really what's considered optimal for immunity in that population. The last thing I'll say is this journey we've gone through in Canada is not happened everywhere in the world, and this is why we're dealing with certain issues now. So certainly there are low and middle income countries where vaccine campaigns, poor housing, and structures that lead to poverty have really led to measles still becoming and staying endemic in many countries of the world. So through Sub-Saharan Africa, through the Southeast Asia and South Asian continents, that we still see measles transmission being endemic. Better in the context of vaccinations, but certainly access has not been perfect. And then over the last 20 to 30 years, we have also seen a reduction in high-income countries in childhood vaccines for a number of different reasons, some of that accelerated by the pandemic itself. And so that's what's really creating challenges. Though Canada has done an incredible job with a vaccine campaign, really making sure that measles does not circulate or only circulates very sporadically in Canada, that the rest of the world, the pressure from measles is growing and growing due to inadequate immunity. And that really then leads to the challenges of us being exposed and re-exposed and re-exposed to travelers coming into Canada with measles, and kind of that wall of immunity, hopefully keeping it under control.
Perfect. We're going to take a quick break, and then when we come back, we're going to talk about some kind of practical questions people might have about vaccination, what they should be asking their primary care providers. We'll be right back after this message. All right, welcome back. Again, we're being joined today by Dr. Zain Chagla. Dr. Chagla is an associate professor of infectious diseases at McMaster University. So we're going to talk, we've obviously talked about measles fairly extensively here, and a little bit about vaccination. So we're going to get to the meat of some questions people would have about vaccination for themselves, for family, and that kind of thing. So I guess the first question is in terms of the effectiveness. Let's talk about that, because that's a question that we obviously have with any vaccines. So for someone who is immunized against measles, let's talk I guess 2-dose series to start. How effective is that in terms of preventing measles?
Yeah, it's a great question. So the good news is it is almost, I mean, nothing is perfect. There are some individuals that don't respond to the vaccines perfectly, but someone who responds well to the 2 doses of vaccines has a 97% chance or higher of not contracting measles on exposure. So very, very effective. There are a small number of individuals because of their immune system that can't make responses. There are a small number of individuals, regardless of their immune system, that still don't make responses for some number of mechanisms. But at a large level, essentially someone who's been exposed to measles, who's fully immunized with 2 doses of vaccine, has a very, very, very tiny probability of developing measles afterwards. And even in those cases, the rashes tend to be very, very mild and recoveries tend to be very, very quick.
And it's considered lifelong, correct? Like once someone's had their
Absolutely. Yeah. Yeah.
series, they don't. A question will come up often from patients who've either had, let's say they've had their series and they come to their doctor and say, I really want to make sure I'm still immune. Could do a blood test. What would you tell that patient? Is
Yeah.
that blood test useful for looking for those antibodies?
No, absolutely. So a couple of things. One is there are some small circumstances where that may be reasonable for certain individuals. But for the vast majority of the population, particularly the population that has fairly functioning immune systems, that we really would consider having that 2 doses of vaccine, really appropriate. And so if there's a question, for example, if people haven't been immunized properly, they're not sure of their records, they've had 1 dose, should I get a blood test done? The answer is just get the next dose of vaccine if you're due for it. And if you've had 2 doses, I think you can be fairly reassured that things are okay in that sense of being immune if you've been exposed. There are some populations where doing that testing is important. So healthcare workers who work with patients with measles, we do want to make sure that their immunity is optimal, and we may ask them, depending on their history, to get serology done. Certain individuals who are just about to become immunocompromised, sometimes if their vaccine histories are not clear, we do measles serology on them, like a kidney transplant, for example, just to make sure that they have the opportunity to get up to date with their vaccines, or at least their vaccines are taking. But for, again, the vast majority of the population, it's not really economically viable. And really, again, if the answer is just getting your 2 doses of vaccine, then it's probably just more important just to get, your full series up to date rather than necessarily worrying about where your blood tests lie.
So we're going to start at kind of the youngest, and we're going to work our way to the oldest. So right now, guidelines are for kids to get their first measles, mumps, rubella combination shot at 12 months of age, and their booster anywhere between 4 and 6 years of age. So those younger kids, can you tell us a little bit about the guidance about, should they be waiting until 12 months? Who should be getting it earlier? When should they be getting it?
Yeah, absolutely. So children between the ages of 6 months and just under a year can receive a dose of an MMR vaccine. Largely, it's funded and provided for children who are traveling, particularly to high-risk settings, where their risk of measles exposure is quite high. It may also be offered for children that have been exposed to measles because of the fact that even getting a measles vaccine within 72 hours after exposure can still reduce the risk of developing measles and actually help with minimizing the symptoms. But those are the children under the age of 12 months that we would offer to. Those children still need to get their full series. So this is just temporary protection for the 6 months or however long that is. They're still eligible to receive their full series when they turn 1 year of age, and should kind of still get their 2 shots that they're scheduled for as they go forward.
And it's something that I warn parents about too. If we give them their shot between 6 and 12 months, yes, it is safe, and it is safe to give their subsequent 2 doses. And the health unit will ultimately require them to get one of those doses at a year of age or beyond, and another one at 4 to 6. Otherwise, they won't consider those 2 doses to be adequate if
100%, yeah.
one of them happened between 6 and 12 months. So just being aware, again, getting the 3 doses is safe, so we're not worried about that extra exposure to them. And then for the children who are between a year of age and between 4 years of age, so they've had that one shot, they haven't yet had their second shot. What are we telling them? What's the guidance for them? Should they wait until 4 years? Does it depend on travel? What kind of things? What's that
Yeah,
conversation?
largely, again, like I don't want to minimize the effect of one shot. It's still very effective to have a single shot in one system, right? So, it's important that clinicians like yourself and particularly people who work with populations make sure those children are at least getting their first shot in. That's the one to focus on to make sure if you're, for anyone listening out there whose kids haven't gotten that first shot, get that first shot because that at least starts the protection and actually is fairly good protection for a few years. It's not 100%. But, for example, when we look at what's happening in Europe in terms of measles, the vast majority of cases are children under the age of 5, and the vast majority of those cases are children that have not received any doses of a vaccine. So, getting the first shot still has significant protection. Some quotes are up to 92%. It's not perfect, but it's still pretty good. And that's where right now the publicly funded vaccine series in Ontario is really not accelerating that second shot in any populations yet. The other nice thing is that the second shot we give at age 4 to 6 is not only MMR, but includes the varicella vaccine. So that's another reason why the timed interval is important, so that extra kind of varicella vaccine is given at that point. There is in discussions now and certainly some discussions around some of our health policy right now in looking if there are particular communities where accelerating that second shot may be warranted. But for now, the guidance is again 1 and 4, unless there's an exposure in the interim where there may be some post-exposure vaccination that we do.
That's good. And then for adults, so anyone born before 1970, so is it 1970 or before? Or is it before 1970? Not
1970 counts towards being
unimmunized.
unexposed, unimmunized. Yeah,
Yeah.
exactly. Yeah.
So anyone born after 1970 who is not sure whether they've had their 2 doses, because obviously, vaccine records may have disappeared between moves, and
Yeah.
their parents may not have them. What should they be doing? Should they be reaching out to their physician? Should they be worrying about this at all?
Yeah, I mean it's good to know, especially if you're traveling. Again, those are where we're seeing exposures. If they've gotten their 1 dose, they think. Again, if you're kind of a person that went on the cycle, that went through schools kind of after 1983, you can at least be reassured you've had a single dose because that's when it was worked through. And again, as vaccination became more more within the schedule, then the vaccination of pupils became part of the school requirements. So, again, folks who were born 1983 or later likely received a dose of vaccine as part of their routine schedule. Folks born 1996 or later likely received both doses of the vaccine. If you're kind of in that cohort that's in between, maybe worth it to look at records, maybe worth it to see what was submitted for school. And if there's still questions, those folks, especially the publicly funded vaccine campaign, is allowed for anyone over the age of 26 or at clinician discretion, or if there's any other major risk factor, that they can receive an extra dose of vaccine in that context.
Those born between kind of 1970 and mid 80s, who, let's say, they have no record of anything. 2 dose series, 1 dose series, assuming that it was still quite a bit endemic at the time. I don't know. I know we're getting a bit nitty gritty here.
No, it's not an unreasonable question. I think again, if they have any school history, that might help with if they've been immunized. At least they're funded for everyone in Ontario is funded for a single dose over the age of 1 year, so that's you can start with that. And again, over the age of 26, an additional dose in certain contexts, including clinician judgment. That person, depending on their wishes and values, and the recognition again that this is going to be not a temporary thing. This is probably going to be a virus that is increasing global circulation. So if people are traveling in any point in their lives, that's reasonable. If they really have not been immunized or very unclear they've been immunized and they're that high risk period where they was not circulating measles, that getting a 2-dose series would not be unreasonable. The doses have to be a month apart, but again, would not be unreasonable in that context.
And you mentioned earlier about if someone's exposed and they get a vaccine immediately, it does have some effect. For those who are, let's say they're going on a trip next week, is there benefit in them getting a shot? Like, does it take effect that quickly enough that would be beneficial to them?
Yeah, so we definitely see that, like, even within 72 hours, we see not necessarily sterilizing immunity, but mitigation of disease and some sterilization that can come from it. So, sooner is better. Most vaccines we say about 2 weeks to get full effect. But if it's a week away to go from vacation, And vacation lasts typically a certain amount of time anyways, and there's lots of exposures even on the way back from vacation, that it's still worth it to consider in that sense. There's no harm for sure.
Again, Dr. Chagla, thanks so much for joining us for all this helpful information about measles today. Thanks so much.
No problem. All the best.
Again, thanks to Dr. Chagla for joining us today and giving us all the helpful information about measles. So again, practical information for you guys moving forward, depending on your age. So if you're born after 1970, making sure that if you're not sure about your vaccination status, following up with your family physician about potentially getting a booster dose. If you have small kids, especially between 6 months and 12 months years of age, and considering travel, getting that dose a bit earlier than would be normally scheduled. Until next time, stay healthy.